Welcome to the deep dive. Today we're looking at your nursing study materials, specifically NCLEX Module 2.
Right, the aging care section.
Yeah, exactly. Our mission today is to really figure out why treating patients who are 65 and older means we basically have to, throw out the traditional healthcare playbook.
You really do. I
Yeah.
mean, the classic treat and street method just totally fails here. It's not like going to a fix-it shop to repair one broken part anymore.
Right, you're managing the whole person.
Exactly, their entire quality of life.
Okay, let's unpack this, because the source points to this thing called the Comprehensive Geriatric Assessment, or CGA, as the ultimate blueprint for aging care.
And it evaluates literally everything.
It really does.
What's fascinating here is why the CGA is so crucial.
Mhm.
Like, it doesn't just tally up a patient's diseases, it looks at their functional abilities.
Like the activities of daily living, right? The ADLs.
Yeah, exactly. Can they physically button a shirt?
Oh.
Or cook a warm meal? And then it uses that data to craft a care plan rooted entirely in their daily reality.
Which is so vital when you're dealing with multiple chronic conditions at once. The source brings up polypharmacy, and, well, managing all those medications is tricky.
Oh, polypharmacy is a huge issue.
Yeah, like managing pills for hypertension, diabetes, and osteoarthritis. It's basically like directing an uncoordinated traffic intersection.
That is a great analogy
Yeah.
because, an older liver metabolizes drugs much slower, so that intersection gets incredibly dangerous.
Right, so the morning blood pressure pill is just like parked in the middle of the intersection.
And then the evening arthritis painkiller comes speeding through.
Yeah.
Bam.
Wow, a toxic crash.
Exactly. So managing 7 different prescriptions in an aging body isn't really medicine anymore. It's essentially a chemistry experiment.
Okay, so with that systemic interconnectivity in mind, I want to ask about these minor physiological changes. The text mentions a high risk of malnutrition.
Right, which isn't just about them suddenly, forgetting to eat.
Yeah, the biological mechanism is wild. Like, as we age, we literally lose taste buds. And at the same time, our salivary glands produce less fluid.
So food starts tasting like cardboard.
Exactly. And it becomes physically hard to swallow, so naturally people just stop eating. But how does that snowball?
Well, it triggers this terrifying physical domino effect. Less food means rapidly reduced muscle mass.
Right.
And you combine that muscle loss with poorer vision, and that directly causes falls.
And a fall isn't just a bad bruise.
No, clinically speaking, a fall in an older adult is often a complete systemic failure. It can mean a permanent loss of independence.
Which is why you have to think about the older family members in your own life. Like, when was the last time you checked if they could easily navigate their own stairs?
Or even just open those tight pill bottles.
Yeah, simple home safety modifications and physical therapy, they aren't just polite suggestions here. They're literal lifesavers.
Absolutely.
But I do have to push back on another point here.
Okay, go ahead.
So, if I'm a nurse, my priority is keeping my patient's heart beating and lungs clearing. But the source treats social isolation like this massive red alert emergency.
It really does.
Right, so why is whether a patient plays bingo on Tuesday being treated as a high alert medical issue?
Because the mind and the body are clinically inseparable. Like, isolation physically accelerates cognitive decline.
Wait, physically?
Yes. When an older adult is cut off from social engagement, their risk for depression, severe anxiety, and dementia just skyrockets. Loneliness is quite literally clinically toxic.
Oh, wow. So community participation and purposeful activities are actual medical interventions.
Just as vital as any pill you could prescribe, it is all about preserving the patient's dignity and autonomy.
Which ties into advanced directives, right?
Exactly. Legal documents outlining their future medical wishes, and palliative care, too, which focuses on daily symptom relief rather than aggressively curing diseases.
Giving them back control.
Precisely. It shifts our perspective from seeing aging as a disease to be cured to a life stage to be actively and carefully supported.
So what does this all mean for you listening right now? Well, understanding these core areas, from the physical mechanics of malnutrition to the toxicity of loneliness, it empowers you.
Yeah, it gives you the blueprint.
Right. It empowers you to better advocate for the aging family members in your own life, making sure they get a compassionate, multidisciplinary approach.
Which is so important as their needs evolve.
Absolutely. Which brings up a really fascinating puzzle hinted at in the source materials for the next module.
Oh, the pharmacology module.
Yeah, We just talked about an aging body navigating slower liver metabolism, swallowing issues, and the severe risks of polypharmacy at that chaotic traffic intersection.
We did. It's a lot to balance.
So think about this. If the older adult's physical baseline is already that delicate, how drastically must standard pharmacological dosage calculations and treatments be altered?
That is the big question.
Right. Like, how do you ensure those medications actually heal rather than cause a fatal crash at the